All right, welcome Facebook Live audience. Thank you for tuning in to join me today for this opportunity I have to talk. My name is Sondrup. I am the chairman of emergency medicine here at Southern Hills Hospital in Las Vegas, and I am an emergency physician. Also wanted to thank Cindy Lundeberg and the marketing team here at Southern Hills Hospital who put this together for us. As I go through this talk today, if you have questions, please type them into your Facebook chat feed, and I can answer them as we go. I have a team here of people behind the camera who are helping me and who will be reading questions to me as they pop up. Also, if you don't get a chance to ask a question or you're watching this at a later date, you can always direct message those questions on our Facebook page, on the Southern Hills Hospital Facebook page. And if you're curious about what's going on here at Southern Hospital and the great things that we're doing, you can always visit our website at southernhillshospital.com. All right, without further ado, I'm going to see if we can work the technology here. As mentioned before, my name is Sondrup. Big focus of our talk today is whether or not the emergency department is a safe place to be. A lot of stuff's going on right now in the world. A lot of people are home. A lot of people are scared to come out and seek medical care. In short, the answer to that question is yes. The ER is a safe place to be. Emergency departments are cleaned like no other place in this world, especially right now. There is a standard of cleaning that we use every single day, even when we're not in the middle of a COVID pandemic, but those procedures have been ramped up significantly in the last few months. So you can always rest assured that places you are going in the emergency department are going to be clean. And we do use virus and bactericidal solutions to clean the surfaces in the emergency department as well as all the rooms where our patients will be. Typically, COVID patients in the emergency departments will be separated from non-COVID patients. Most emergency departments have already decided how to do that. Provider hand hygiene, is a must in hospitals and has been exaggerated even greater over the last couple of months. You'll notice that doctors and nurses and nurse practitioners are constantly washing their hands, and that is in an effort to try and stop the spread of any virus, not just coronavirus, but all viruses. Also, in most hospitals, you'll notice that most of the providers are wearing similar clothing or scrubs. At Southern Hills Hospital, everybody who works in the hospital is given scrubs for each of their shifts. So we come to work in normal clothes, we change into hospital scrubs for our shift, and then we leave those scrubs at the hospital when we go home, so as to not take virus or any pathogens out of the hospital. There are visitor restrictions at Southern Hills Hospital and most hospitals in this country right now. It is very common for locations in the hospital to not allow visitors. And part of that is to prevent the spread of a virus within the hospital. There are places in the hospital where you can have visitors. The emergency department, for example, will allow one visitor. ICU will oftentimes allow a visitor. Up in labor and delivery, there are other places where you can have visitors. But please be aware, visitors will be restricted. And the reason that visitors are restricted is it helps prevent the spread of any infectious disease. Perhaps one of the things that we do, which is better than any other, is putting masks on patients. You'll notice most, if not all, of the patients in the hospital will have a mask on them. One of the reasons we think that's the most impactful is because we believe this virus is spread through coughing and sneezing. And if you can stop a cough and a sneeze right at the face of somebody who's infected, it goes a long way towards preventing any spread of the virus. Rooms in our emergency department have doors. There's a reason for that. We like to place all COVID patients or suspected COVID patients in rooms with doors and those doors closed. We also have HEPA filters in our rooms, and we have negative pressure rooms to prevent the spread of infection to other patients within the emergency department. And for those of you who don't know, a negative pressure room is a room where inside the pressure is lower than outside in the hall, such that if you open the door to that room, air is actually sucked in from the hall into the room. Now you can imagine the alternative would be a positive pressure room where there would be higher pressure inside of a room than outside the room. And if we open the door, it would then blow air out into the hall. So by having a negative pressure room and keeping sick patients in those rooms, we can prevent any pathogens or viruses from being spread throughout the emergency department just by opening the doors into the hallway. Hand sanitizer. Hand sanitizer is all over the emergency department. It's all over the hospital. It's been like that forever, but it's even more emphasized now that we're in the middle of this pandemic. And you'll notice providers in the emergency department are washing their hands when they go into a room. They're washing their hands when they go out of the room. They're washing their hands whenever they think about it. It's actually working quite a bit. Many of you will remember the New York study that everybody keeps referring to on news stations and online about when they did all the serology testing of those New Yorkers. And based on that study, they were able to make some estimates of how many people have actually been infected or exposed to coronavirus. And one of the things that they found was that far more people were exposed to coronavirus or infected with coronavirus than they had previously thought. And they made that assumption based on antibodies in people's blood. So very interesting, because it told us that this virus has probably been around a lot longer than we think. It also told us that many people are getting this virus who didn't even know it. And it also tells us that the mortality rate was much lower than we had originally thought. One of the things that also came out of that study, which was very interesting to me, was healthcare workers. They found, or they estimate, based on the results of that study, that far fewer healthcare workers have been exposed or infected with coronavirus than the general population. Seems kind of counterintuitive, considering healthcare workers are always in the hospitals and in the emergency departments where these patients pretty much reside for a large period of time. But what experts are surmising is that the precautions that healthcare workers are taking, the precautions that hospitals are taking to slow the spread of this virus, are actually working. And it's making it so that the healthcare environment is actually probably safer than being out in the general public when you're concerned about virus transmission. So I want to talk a little bit about emergency medicine and what is emergency medicine. Since we're talking about what to expect when returning to the emergency department and when and why to return to the emergency department, I want to talk a little bit about what the emergency department is. So we first have to talk about what's an emergency. And the way you define an emergency varies from person to person. But one of the most widely accepted definitions of an emergency is any condition that, if not treated within a reasonable amount of time, will result in loss of life, limb, or bodily function. Right? It's a very vague definition. But if you think about it, you think any condition that, if it doesn't get treated now, could cause some serious impairment in my life, qualifies as an emergency. Federal law also includes severe pain in the definition of emergency. Emergency physicians are actually board certified and trained specialists in emergencies. Now, what does that mean? There's a lot of confusion about that throughout the community. What that means is an emergency physician is very similar to a cardiologist. We differ in specialties. Cardiologist is a specialist of the heart and the cardiovascular system. An emergency physician is a specialist in emergency medicine. They are trained to identify and treat emergencies. Now, that doesn't mean that an emergency physician knows nothing about cardiology. But what it means is the emergency physician is very keen to the emergencies related to cardiology or the emergencies related to any other specialty. In the emergency department, we also have allied health providers. That is a fancy name for nurse practitioners or PAs. And every emergency department you go to will have different names for allied health providers. But these providers are also highly trained in emergency medicine. The goal of emergency medicine is to identify and treat emergencies. That's what I'm trained for. That is what an emergency department is set up for. When you have a problem and you don't know if it's an emergency, we are the place to come so we can help identify and treat any potential emergencies. ER doctors are actually trained in the emergency presentation of all specialties. And that's an interesting thing to think about because we are specialists, but as specialists, we need to understand the emergency presentation of every other specialty. So for example, ER doctors are trained to deliver babies in emergency situations. We're not obstetricians, but we are trained to do that in an emergency. Emergency physicians are trained to do cardiology procedures in an emergency. We are trained in neurology in an emergency. And if any of you have suffered a stroke or have a family member that suffered a stroke, the person who treats that stroke is oftentimes an emergency physician when a patient presents to the ER. Now, what that also means is emergency physicians are not that great in the long-term care of specialties or patients who require specialty care. So if you have a stroke today, great. Emergency physician is going to be your best friend for the first couple hours of that stroke. But afterwards, your care is going to take many, many months or even years. That's when a specialist is very, very important. A specialist in neurology or any other specialty for that matter. So another question that I know always comes up is, why do ER providers move so fast? And when I say providers, I generally mean doctors and nurse practitioners and PAs. Now, I thought this was a good opportunity to discuss with the public about why that is, because I understand it's annoying, very frustrating to be a patient in an emergency department and feel like somebody just breezed in and breezed right out and didn't take the time to sit down and talk to me. I get that, and we really do try as emergency providers. We try to listen, we try to spend time with our patients, we try to do everything we can to get the full picture. But I wanted to give a little bit of background as to why that happens in most emergency departments. And that's because emergency practitioners or providers have a very specific purpose and duty to find an emergency when patients show up at the hospital. We are very emergency focused. So when you show up to the emergency department with chest pain, we are focused on potential emergencies. What could the potential emergencies be? And there's quite a few that run through our head every time we're talking to a patient. What that also means is oftentimes emergency physicians will not spend a lot of time talking about stuff that isn't related to the emergency. And they oftentimes will move past that in order to obtain information related to somebody's specific emergency condition. We're also responsible for multiple patients at the same time. Emergency departments are busy. There's lots and lots of patients there. And any emergency physician may at one time be responsible for anywhere from 10 to 15 patients at one given time. And those are all patients who need things, who need medications, who have pain, whose situations change. And that's one of those driving forces that keeps emergency physicians moving very quickly. Also, we're responsible for patients who may not even shown up to the emergency department yet. In the back of the mind of every emergency provider is, could there be a stroke on its way in by EMS that's getting here now? Could there be a heart attack waiting in the lobby? And because of that, because of the duty to identify and treat those emergencies, we inherently will move a little bit quicker. We do know that the sooner a patient is seen by a provider in the emergency department, the better off their care will be. The more likely it is to identify and treat any potential emergency that someone may have. Got a question from the audience.
Ari, A-U-R-I. I have a question, for example, about the radiology or TAC unity. If we are having in mind that the aerosols last 3 hours to disappear, what happens if before a non-infected patient needs to be there, but before a positive COVID-19 patient was there?
So having a hard time understanding the question, but I think the answer to your question is, number one, we don't really know a lot about the aerosolized particles and how long viral particles are going to be suspended in the air around us. Most of you probably saw online, I think it was released earlier this week, CDC actually released a report stating that they actually don't think this virus is transmitted from surfaces the way that they thought before. When this whole thing started, we were all so scared about touching doorknobs and touching tables and chairs and so forth because we were convinced we were getting it. And at the time, the CDC was also convinced. As we are obtaining more and more data, the CDC is now saying that they're not so sure that that's even true. They are convinced still that there is person-to-person contact. So when we talk about aerosolized particles in a room, the honest truth is nobody knows. Nobody knows if there's aerosolized particles in this room right now where I'm standing. Nobody knows if they're in the emergency department. We don't know if they're in the grocery store when we go and we visit a grocery store. The unfortunate part is aerosolized particles will oftentimes get through a mask. We can wear masks, we can do everything that we can, but aerosolized particles, unfortunately, they're around us and we live with them. And I'm not so sure that there's a way to prevent aerosolized particles from getting to anybody That being said, hospitals are doing everything they can to try and prevent the spread of the infection. And oftentimes hospitals will have radiation lights where they clean rooms, the idea of which is to clean even the air in a room. There are time periods between using rooms in some hospitals. They'll say if there was an infected patient in this room, we're going to wait, and then we'll wait a certain amount of time before we bring another patient into that room. So I hope that answers your question, Ari. Thank you for asking it. If there's no other questions, I'll go ahead and move on. So I wanted to talk a little bit about chest pain, or when to go to the emergency department. So a lot of people have stayed away from the emergency department over the last couple of months. We recognize that. We appreciate that. That actually helps with the pandemic. That being said, there are some things where you should not stay home. You should feel comfortable going to an emergency department, and you should not procrastinate. Chest pain is one of them. The reason we always say chest pain is one of them is because one of the leading causes of death in this country is still heart disease. And if you're sitting on something that could potentially be a dangerous heart condition, home is not the place to be. Now we realize a lot of people will come to the emergency department and a lot of people will be told their heart is fine. That's great. That's perfectly fine with us in the emergency department, but we would rather check. And we feel really uncomfortable when people stay home with stuff like chest pain. Now that doesn't mean everybody that's got chest pain is having a heart attack. Most of you know that you've had chest pain at a time or two in the past. But we certainly do worry a lot about older folks, folks with a lot of medical conditions, staying home when they've got chest pain. And certainly as the quarantine and the pandemic went on, we did start to see a lot of people coming in who were waiting it out, whose heart problems advanced to a stage where it became much more difficult to treat because they waited and they didn't come in early enough. Difficulty breathing is another one. Anytime you've got difficulty breathing, you probably should seek care from a provider. In the emergency department, we're here to treat that. We're here to work that up. It can represent a lot of emergency conditions. Anything from heart disease to infection to cancer can present with difficulty breathing. Unfortunately, it's a very vague symptom, and it's oftentimes very difficult to work up in the emergency department, but it can be a sign of an emergency condition. Severe pain. We say severe pain because it's hard to tell people every potential presentation of an emergency. But severe pain is one of those things that can be a very big red flag, especially abdominal pain. The abdomen is so complex that oftentimes the only way to know if you're potentially having an emergency is pain. And even when you come in with abdominal pain, it's very difficult for an emergency department to get to the bottom of why somebody has abdominal pain. But emergency departments are very well tuned to identifying emergencies that present with abdominal pain and other severe pains. So if you are feeling severe pain, that's another reason not to procrastinate, especially if it's new pain. Neurologic symptoms. So this is a big one. Stroke is one of those conditions where you have to get to an emergency department within a specific amount of time if you want to get treated. And to be honest, that amount of time is between between 3 and 4.5 hours. Now that is a window of time in which we can treat most stroke patients. After that, it becomes very limited on which patients can actually be treated for their stroke. So we always ask people, if you're having neurologic symptoms, come in immediately. The sooner the better. Typical neurologic symptoms of a stroke would be any one-sided weakness. So that's weakness of one side of your face, one arm, one leg, or all of them together. That's a concern. Any speech changes that happen suddenly could be a stroke. Any confusion or change in your mental status that happens suddenly, that could also be a sign of a stroke. And then rarely, but it does happen, severe dizziness that comes on all of a sudden can also be a sign of a stroke. Other reasons to come to the emergency department, if you're just unable to keep down food and water or liquids, you're not going to last very long at home on your own. You come into the emergency department, not only can we treat that, but we can also work you up for potential emergencies that might be causing vomiting or diarrhea. Inability to care for self. This is another one that helps us to identify any potential condition that might be an emergency. Oftentimes people will come in just because they feel so weak or downtrodden that they can't take care of themselves. And we'll identify something like pneumonia or a urinary tract infection. Inability to care for self, especially in the elderly, is oftentimes the only red flag or the only sign that an emergency is happening. And then anything else that somebody thinks might represent an emergency, anything else that's new or different or strange to you as the patient might represent an emergency. We are the place for you. Severe depression. So certainly during these current times that we are in, we need to at least acknowledge severe depression and suicidal feelings. That is something that is becoming more and more of an emergency, especially nowadays when people are having a difficult time with work. If there is any sort of severe depression or suicidal feelings, you need to come in and get treated immediately. Emergency departments do have protocols in place. They have ways to get people the help that they need when they are in these situations. We at Southern Hills Hospital have a behavioral health unit, or hospital, sorry, it's not even a unit, it's a separate hospital associated with our hospital where most of these patients are being treated. And then any serious injury requiring immediate care is something to come to the emergency for. That's pretty obvious usually. When you break a leg and you can't walk and it's crooked, most people know to come into the emergency department. But I wanted to include it just so that we kind of had a comprehensive list or idea of what might represent an emergency and why to not procrastinate emergency care. So any emergency department talk would be incomplete if we didn't talk about EMTALA. Most of you probably don't know what EMTALA is. I don't blame you. Most people do not. Emergency physicians live and breathe EMTALA. EMTALA is a federal law that was enacted, I think, back in the 80s to prevent emergency departments from dumping patients. So for example, somebody would come in, they didn't have insurance, no one wanted to take care of them. They would put them in an ambulance or a taxi cab and they would send them somewhere else. Seems crazy. Seems crazy to me because that was long before I started practicing emergency medicine, but apparently that happened. So EMTALA was enacted by the government, and part of this law mandates that anybody who shows up to an emergency department will be evaluated, they will get an emergency medical screening exam, and they will have those emergencies stabilized or treated. So big things to remember in there is emergency medical screening exam. All right? Now, EMTALA does not mandate that everything gets treated when you show up to the emergency department, but it does mandate that you will have an emergency evaluation. Right? Now, it doesn't matter if you can pay for it. The law has no stipulations as far as payment are concerned. It applies to everybody who shows up at our doors and is seeking emergency care. So talk a little bit about the process of emergency care. So a lot of these numbers come from Southern Hills Hospital, because that's where I work, but they are also applicable to multiple emergency departments, especially our sister emergency departments here within Las Vegas, being Mountain View Hospital, Southern Hills, or Sunrise Hospital, and even our satellite emergency departments, ER at the Lakes and ER at Aliante. These times that I'll be talking are pretty much the same at all of these facilities. So greet times. When you hear people talk about an ER greet time or a wait time, they're usually talking about the time that it takes from when you sign in the emergency department until an ER provider comes and starts talking to you and evaluating you. Now, sometimes that provider is a doctor. Sometimes that provider is a nurse practitioner or a PA. That time, the greet time that we're talking about, is the time in between there. That's your wait time. Now, wait time does not mean how long you're going to be in the emergency department. It basically means how long are you going to wait to see a provider. At Southern Hills Hospital, those times are consistently less than 10 minutes. Our average right now is actually 4 minutes. But we in this valley, who are within the Sunrise Consortium of hospitals, we have a goal of getting to everybody within 10 minutes of signing into the emergency department. And every emergency department in this valley does very well at meeting that metric. Orders are placed by a provider shortly after they see you. So you'll wait your 10 minutes or your 4 minutes or 2 minutes, then that provider goes and places orders in the computer. Now this slide is a little bit about what you can expect as far as turnaround times on those orders. So I got these numbers from Southern Hills Hospital. Our average lab turnaround time, that's when they draw your blood, they send it to the lab, and they do some tests. Average turnaround time is about 40 minutes. Now that varies between 30 minutes and about 55 minutes depending on the test that's ordered. But you can expect on average about 40 minutes to get that laboratory test back. Certainly when there's patients who are a little sicker and they've got more tests stacked up, it might take a little bit longer. But those are the average times that we have. Radiology turnaround times. Overall, radiology takes about an hour. It says here 66 minutes. So you can expect, on average, an hour to get your radiology test back. Now that obviously varies depending on the modality of test that's done. A CT scan, on average, takes about an hour and a half, or 96 minutes. An ultrasound, on average, will take us about 70 to 75 minutes. And there's various reasons why that is. But x-rays, for example, 40 minutes. They're usually the shortest of all of our turnaround times. So length of stay. Length of stay is also something to be aware of when you come to the emergency department. Our discharged patients at Southern Hills Hospital are out, on average, are out the door within 120 minutes. All right? We have very specific goals, and I actually watch those numbers every day to make sure that we are meeting those goals. Now that is an average, so that means some people come in and they're discharged within 15 minutes. Sometimes it's a very quick screening exam and a very quick process and treatment. Sometimes they come in and they're there for 3 hours and we discharge them home. But on average, 120 minutes, right around 2 hours, is what you can expect to spend in the emergency department at Southern Hills Hospital. Admitted patients, it's right around 3.5 hours, 200 minutes. So that's the amount of time, if you're admitted to the hospital, that is the amount of time that you will spend in the emergency department. From the time you sign in till the time they start wheeling you down the hall and upstairs is approximately 200 minutes. Our admission percentage at Southern Hills Hospital is 25 to 30%. Now if you look nationally, that's a little bit higher than the national average. And the reason that is because we have a lot of sick patients that come in. We're very close to a large, very successful cancer treatment center. And we're in Las Vegas, and there's a lot of snowbirds who live in Las Vegas, a lot of retirees that live in Las Vegas. So because of the acuity, we tend to admit a relatively large number of patients to the hospital. Discharge. Most patients, sorry, I'm being told to move over a bit. Apparently nobody wants to see me that much. Discharge patients. So most patients that come to the emergency department are actually discharged home after their visit. So what that means is the workup will be done, the ER doctor or provider will come in, talk about the results, talk about a plan, and then somebody gives you some paperwork, likely a prescription, and then they'll say it's okay to go home. One of the things to be aware of when it comes to emergency care is if you're coming by ambulance, please anticipate that there's a good chance you may be going home after your visit. Remember I said, as high as 30% get admitted to the hospital. Well, that means 70% of the patients are actually being discharged home from the hospital. And a lot of people come by ambulance and have a difficult time finding a ride home. I think I saw a question from the audience.
So Abby wants to know, she is a diabetic type 2. She wants to know if she's an EVS worker. She wants to know if she's high risk when cleaning the aerosol rooms if it has not been 3 hours.
So Abby is asking about whether or not she's high risk because she is a type 2 diabetic. I don't know that I can tell you for sure that you are high risk. That depends on a lot of things. It depends on your age. It depends upon other medical problems that you might have. I will tell you, Abby, I'm a type 1 diabetic, probably high risk as well, but we take precautions. We wear masks, we wear gloves, we do the best that we can. In all reality, nobody knows how high risk I am or how high risk you are. We do the best that we can, and we do our jobs, and life goes on. The honest truth is the best masks that are available if you're trying to protect yourself are the hospital-grade masks that we have. All those masks that we see people wearing out on the street, those really aren't going to protect them from aerosolized particles. That's the honest truth. The only ones that can protect you from aerosolized particles are the ones that you are given in the hospital when you are working there as somebody who's cleaning rooms, for example. That's the best way to protect yourself, but the honest truth is we don't really know for sure. But thank you for the question. All right, I already spoke about that. So just because you're discharged from the emergency department does not necessarily mean that nothing is wrong. Every day I go to explain the results of a workup to a patient, and I tell them that everything came out okay. We didn't find anything abnormal. And the first thing that patients ask is, so does that mean there's nothing wrong? The answer to that is no. It doesn't mean there is nothing wrong. What it means is the emergency workup that we have done has not revealed any life-threatening emergencies. Now, we know there's something wrong because you're in the emergency department. You're feeling pain, you're short of breath, or you're weak, or you're having chest pain. There's definitely something wrong. Remember, those signs, those are signs that your body is giving you that there's something wrong. The question that we answer is, what is the chance that it's a life-threatening emergency? And oftentimes, we get to a point at the end of our workup, everything comes back normal, and we can say, look, the chance of you having a life-threatening emergency is very, very low. But remember, just because you're going home, it does not mean that nothing is wrong. The reason we constantly tell patients that is because oftentimes patients will go home and things will change. Pain will get worse. Pain will migrate to some other part of the body. Something else will turn up or happen. Those are reasons to come back to the emergency department. Those are signs that perhaps the workup will be different. Perhaps the workup will change next time you come in. Maybe something else is going on and we just happen to not pick it up when you were in the emergency department the first time. That's also the reason we always recommend patients follow up with their primary care provider or with a specialist after they leave the emergency department. And emergency departments will all give you a name on those discharge paperwork. They'll say, follow up with Dr. So-and-so. That is for you to continue your workup so that you can close the book or close the loop, so to speak, on whether or not you have a life-threatening emergency, for sure. Another question from the audience.
This is from Kara. The ER must be one of the most susceptible populations for COVID. Someone comes in with a hip fracture and they need to operate right away. Do you feel that everyone in the ER is taking the right precautions to stay safe?
The answer to that is yes, I do. Sorry, this was from Kara. Apparently I didn't read the question. Kara asked, do I feel that everyone in the emergency department is taking the appropriate precautions when patients come in for other non-COVID related complaints? Do I feel like the precautions are being taken to protect patients from getting COVID? And the answer to that is yes. I feel like we are definitely taking extreme precautions and extreme measures. Now, you have to keep in mind that nobody really knows exactly what this virus is doing. Nobody really knows exactly the best way to protect ourselves. So we're kind of doing everything that we can and everything that we can think of. And still, the patients coming into our hospital, very, very few of them are being diagnosed with COVID. The vast majority of them are coming in with hip fractures, and they're leaving with just hip fractures. They're not getting the virus. I hope that answers your question. Sorry, I think I'm done with this slide. So uncertainty. So when you come to the emergency department, one of the things to always remember is there's always uncertainty in that diagnosis. So if you come in with chest pain, and we do a whole bunch of tests and a whole bunch of workup, and we determine that your risk of having a heart attack or any emergency is low, we may say, okay, it's okay to go home and follow up with a cardiologist or follow up with your primary care doctor. There's still some uncertainty there. Remember, no workup is 100%. Human body is not a car. We can't plug it into a computer and have it spit out exactly what's wrong. The human body is the most complex thing ever created. And unfortunately, our minds and the technology that we have to work up the human body is still not adequate enough to figure out exactly what is wrong with everybody who comes in. Now, we are dang good at finding out whether or not somebody has an emergency, but there is still some uncertainty. So one of the things to always remember when you leave the emergency department is it's not a 100% clean bill of health. When things change, and sometimes they do, that's time to come back to the emergency department to be reevaluated. So all ER patients who are discharged can and should return for any new or worsening symptoms. Remember, a normal workup does not mean that nothing is wrong. I think I already talked about what this slide says. So specialist care in emergency departments. So oftentimes I have patients come in and they say, well, why can't I see a gastroenterologist right now in the emergency department? And the answer to that is, well, it depends on the severity. And that applies to any other specialist, gastroenterology, cardiology, neurology. It depends on the severity of somebody's illness. So all emergency departments have an ER call panel, which is basically a list of specialists who are on call to provide emergency care. So these might be gastroenterology, these might be cardiology, and basically the key phrase there is provide emergency care to ER patients. So can they come into the emergency department? Absolutely. But only if there is a life-threatening emergency identified do they come in. And the reason that is because these surgeons and gastroenterologists, they have full clinics and they're working in their clinic. And so calling them in, it is available. I can call somebody in, but if I do, I need to call them in for something that I am unable to manage, something that is so dangerous or so severe that if they don't get in now, a patient might have a serious outcome or a bad outcome. So oftentimes when people ask that question, why can't you call a cardiologist to come see me now? It's because a condition that they have right now does not warrant an immediate cardiology evaluation. It doesn't warrant me calling the cardiologist in his office and saying, hey, you got to drop your load of patients and you got to get in here and see this person now. Call panels actually vary from ER to ER. Here at Southern Hills Hospital, we have general surgery, we have gastroenterology, we have cardiology, we have orthopedics, neonatology, neurology, neurosurgery, and OBGYN. I'm sure I'm forgetting someone, but over the last couple of days, those are the only ones that jumped into my mind. And then obviously we have emergency medicine. We're not on a list of call because we're always there, but we are definitely one of the specialists that provides services at the hospital. Specialists are only required to see patients in the ER when there's a severe emergency, as I explained just a minute ago. And that emergency is basically something that cannot wait to be seen at another time. That's when you will see the emergency physician call in the surgeon or the orthopedic surgeon. So, in summary, is the ER a safe place to come? Absolutely, it's safe. I've been working there for 10 years. I feel safer there than most places I go because I know in the emergency department, I know where sick patients have been. I know that those places have been cleaned. When I go to the grocery store, I don't know where sick patients have been. I don't know what people have touched, and I don't know who's got what illness. Do not procrastinate. So a whole list of things that we shouldn't procrastinate. We just went over them. Just remember, there are some things that you want to get evaluated for, especially during a pandemic, even during a pandemic. All emergency patients, all ER patients will receive an emergency medical screening exam. No workup is 100% accurate. We are very good at doing the workup, but sometimes things change. And remember, if you are getting worse, that's time to return to the emergency department. That's the end of the slides that I have. I am available for questions from the audience. And if we don't have any questions, then that's great. I'll stand here for a minute and look like a fool, and then we'll turn off the live feed.
Is there anything else you want to reiterate?
Oh, this just in.
Breaking news. Am I a high-risk person? I was thinking about it the past few days when I was reading that this virus can cause lung hypercoagulation in some situations. Here you go. You can read this one.
I'm just going to read this one.
Sorry, I'm not clinical.
All right. This is from Ari. Ari says, am I a high-risk person too? I was thinking about it in the last days when I was reading that this virus causes lung hypercoagulation in some situations. I am MTHFR677C mutation. It causes blood clotting issues. I have been taking a baby aspirin for a long time. That is why I'm very careful. But you are right, this is a new disease. We don't know enough. So the answer to your question, Ari, is it's a new disease. We don't really know for sure. But the evidence that we have suggests that the mortality rate is far lower than we initially thought. I wish I could give you a clear-cut answer. I don't know. We do know that there are cases of patients getting blood clots in their lungs and in their legs who we don't think would have otherwise. And so we suspect that the virus can increase the body's ability to clot. And so, you know, if it were me and I was a little bit, or I was at risk for blood clots, I would take some extra precaution. You know, as things open up in the community, there are still people in the community who are going to have to take extra precautions. We can't just open the door and flood the streets. Well, I shouldn't say that. We can if you feel comfortable with it. But, you know, people in general have to know themselves, and they have to take precautions that are appropriate for their own medical conditions. And unfortunately, if we don't know, it may be a little bit longer for people, for some people, than for others before they can venture out. Another question.
This is from Susan. Should a healthy person get a COVID test?
Susan asks if a healthy person should get a COVID test. If you are not having symptoms, the answer to that is no. So the tests that they do for COVID are to test if you actually have the disease. And that's the one where they stick the swab down your nose and they send it to the lab. So there's some limitations on the test itself. There are plenty of cases of people who have been tested and come back negative, but actually had the disease. There's plenty of cases of people that got tested 3 times and it took them 3 tests before they finally tested positive. And that's just because of the inherent limitations of the test itself. So you have to understand that, you know, testing yourself has its own limitations. It may come back negative. Does that mean you don't have the disease? Probably, but we don't know that for sure. You might still have the disease, even if the test comes back negative. So what I've been telling people is if you don't have any symptoms, don't worry about being tested. One of the things we learned from the New York study and the USC study is that a lot more people have been exposed, immunized, and infected with this virus than we even know. So it's possible that all of us who are standing here who don't have symptoms today have been already infected with this virus back in January or December when we all just thought it was the flu. No more questions?
Yeah.
That's it. Thank you guys very much. Please remember you can always visit the Southern Hills Hospital Facebook page, and you can also visit our website at southernhillshospital.com for any more information. Thank you.